Alquizwini Umberto Benedetto. The topic is short and long-term results of minimally invasive direct coronary artery bypass versus full sternotomy revascularization in isolated LAD disease, a propensity score adjusted comparison.
Good afternoon. My name is Iman Alquizwini, and I'm going to be presenting our study looking at the revascularization of isolated LAD disease, comparing the mid-cap and full sternotomy outcomes within our institution. I'm just going to very quickly go through the background. You all know it, so it's just to touch on it, go through the aims of our study, how we conduct the study, and then the results, and hopefully a bit of a discussion about where this goes in the future. So as we all know, the Lima to LAD is a well-established method. It's the gold standard for treating LAD disease. The mid-cap provides an opportunity to do that graft without the need for a full sternotomy through a minimally invasive anterior thoracotomy incision and off bypass. So there are many theoretical and sometimes proven improvements in adopting this technique versus a full sternotomy. However, there's a great inertia especially in London and in the UK, in doing the mid-cap procedure versus the full sternotomy. And there seems to be a reluctance of surgeons to adopt the technique, perhaps because they're concerned about the long-term outcomes versus the full sternotomy. However, when one looks at mid-cap versus PCI and stenting, it is well documented that the mid-cap and the Lima to LAD graft is superior to stenting in treating disease. So the aims of our study was to compare the long and short-term outcomes after the mid-cap versus the full sternotomy revascularization with isolated LAD disease within our institution to evaluate safety and efficacy. How did we do this? So we looked at all the CABGs done from April 2001 until May 2013 within our institution. We retrospectively analyzed the data, but that data was collected in real time within each operation. It was connected on our institutional database, which looks at preoperative, intraoperative, and postoperative data. We looked at late mortality figures from the general registrar, and we picked up figures on repeat revascularization from national databases. The inclusion criteria, we only looked at patients who had first-time operations. It was only a Lima to LAD graft that was required, either via full sternotomy or via the mid-cap approach, but all were off bypass. So all of them were off pump surgery. The outcomes that we analyzed, we looked at short-term and long-term outcomes. The short-term outcomes are up on the board. We did a composite analysis with all the adverse outcomes in addition to looking at each outcome by itself. And we looked at all-cause late mortality and freedom from repeat revascularization as our main long-term outcomes. We used propensity score matching based on 17 pre-treatment variables that are on the next slide, and we tried to analyze for estimation of treatment effect and used a parametric survival model to assess our time-related outcomes. And these are our pre-treatment variables that we looked at. So how did our numbers add up? Well, in terms of total numbers, within this time frame, we did 159 full sternotomies and 318 mid-cabs. Before matching, there was a significant difference in the pre-treatment variables, but after matching, the covariates were quite well balanced, and our mean follow-up time was 6.2 years after matching. When we looked at our short-term outcomes, for most of the outcomes, there was no significant difference between the groups, so those who had full sternotomy and who had the mid-cab approach. Specifically, the operative mortality was similar, and the median length of stay was about 6 days for both. However, when looking at the rate of wound infections and the overall adverse events, the patients who had the mid-cab did better than those who had the full sternotomy, and p-values up on the screen, so significantly so. And then when looking at the long-term outcomes, those who had a full sternotomy did not have improved survival compared to a mid-cap and did not have a relative risk reduction for repeat revascularization. So having the full sternotomy did not confer an advantage to having over the mid-cap for the majority of these patients. So the basic conclusions is that we found through our study that it is a safe and effective method to use for revascularization in terms of isolated LAD disease. The perioperative mortality is comparative, and that's in line with what has been found with other studies in the past. Additionally, the short-term outcomes are also in line with previous studies, so there's no disadvantage to having the mid-cap in the short term, and that's something that's found in repeated studies. In terms of long-term survival and freedom from repeat vascularization, we actually found that we had excellent results with the mid-cap, which were comparable, if not slightly better, than the stenotomy. However, previous studies have found that in the midterm, the adverse events associated with mid-cap are slightly higher than those for stenotomy, and that may be sort of as a result of the experience of the surgeon performing the surgery. Within our study, there was a single surgeon performing all the mid-caps, and he was quite experienced, so that probably reflects on our excellent outcomes in the long term. Just on final words, so we've seen a trend towards improved outcomes in the short and long term with the mid-cap, and it does remain a valuable therapeutic option both for isolated LAD disease and also for disease that's not stentable. However, you do need a certain level of experience required within your institution to obtain good results in the long term and to make it a more viable option. Thank you very much.